watching Cablevision, Channel 14, local origination programming, your hometown network.
Welcome to Mind Over Matter, and today is a treat. It's a real treat for me, a privilege to introduce Dr. R Hartman, who is Professor Emeritus, Boston College School of Nursing, who has been very much interested in how this work affects the providers. And that's not just mental health workers, that's across the board, people who provide human services.
Right.
So perhaps you could talk a little bit, Carol, about why the doctor, but really why providers tend to get cranky and what that phenomena is really all about.
Well, you know, George, maybe a little story gives an example.
Okay.
You know, as an example. I was called back to teach a course again at Boston College this year. And I no sooner was walking down the hall into my office than a colleague stopped me, very upset. And it had to do with a real confusing and upsetting hospitalization of her middle-aged son, who had his first had a first breakdown over what wasn't really clear. And at the core of the issue that my colleague kept bringing out was, first, in the emergency room, there was a fight between doctors over who had jurisdiction over the patient and what should be done. One wanting to do more of an evaluation and one saying, no, this is what it is and let's treat it this way. And then the admission, of course, is on that marvelous day, Friday. So her son's on the ward for 2 days, very confused, almost like he's toxic on a psychiatric unit. And she isn't seeing him getting any treatment or getting better. And so made a request to change the hospitalization. And the result was a physician came up on the ward kind of screaming to the nurses, who does this person think they are, wanting to change? I was assigned to this patient, this is the first time I've heard of it, etc. So now we get to the cranky doctor. And I hear these stories over and over in a variety of settings, and certainly as a consumer of health care services through my lifetime, have witnessed these kinds of issues, whether doctors or nurses, social workers or other care providers, the cranky police officer, working with people who work in the prisons where you've worked, etc. And it's always been a concern of mine, and particularly as I've retired and gotten older. You know, Gerald Kaplan said something very important. If we have healthy institutions, the people that come through them for the services will get the best services and come out of it healthy.
So go back to your colleague.
Yeah.
So she encountered a cranky provider. How did that impact on her, and how did she deal with it?
Well, she was horrified.
Okay.
She was very horrified. She just couldn't understand what was going on. And her son she did get the transfer and everything, and so that worked out. And she wanted to know what to do about it. And I said, I think things like this need to be reported to the overseers who are contracting, etc., to go on, because this kind of situation spells out for me that there's really stress within the organization and system itself.
So like what
and
now?
So it's impacting on the doctors.
Okay.
This isn't doctors who want to be mean or crabby. No, it isn't a nurse who wants to be mean. People want to do a good job.
So
what's
speculate about that scene. Now let's go to the
Okay.
providers. Why do you think the doctors were mad at each other? And
Already we see that there is confusion over how to work in a crisis in the emergency room and the assessment. What are the procedures there? How are teams built to go in and deal with these cases to begin with? Is there supervision there? And that's a critical factor, particularly this day and age. The issue of managed care, let's talk about the issue of managed care. The idea of managing care and doing it in an effective way and making sure the right treatments get to the right person, etc., makes sense. The tension resides when it is what I call corporate care, which is management by how much it costs, and cost becomes the issue. This begins to set up a structure that may not be conducive to the clinical working relationships that are needed in a system. In other words, where is the supervision? Where is the organization of teams? Where is the case review going on in these situations? Not pointing blame, but when these things happen, where are they being evaluated? Now, if people, you heard, the thing that clicked in my mind was the doctor said, I was off and I got to sign this patient. Meaning that the continuity is broken. And all of a sudden, he feels on the spot because now the patient, the family's mad and they want to take the patient out of the hospital. And what does this mean in terms of cost, et cetera, and management?
But we can't blame managed care altogether. I mean, so
No.
he's upset because he's got one more case and he's got too many cases?
It could be one more case, or he is upset because the way cases are assigned, he wasn't there from the beginning and he isn't well introduced to what he's dealing with. But he's put on the spot and there's criticism of the care.
So he's mad.
So and he's short fused, which means this isn't the first time it's happened. Okay. You know, that the dilemma, that would be my speculation.
But he's in a setting where he might be overloaded with too many cases.
Absolutely.
And then superimposed in this anecdote
Right.
is that then suddenly there's the threat that he's mad he's got the case, but he's even more upset he might lose the case.
Right.
That someone's
Right.
taking it away from him.
And he's upset with the fact that he should feel that he's in control of information that he's not in control of. So we have some problems in the networking and the communication. And the more people feel that they can't be in control of what they're doing, the more stress they're going to feel, the more they're going to be limited in their perspective of what to do, the more they feel other things unpredictable or out of their control are going to take over. And this kind of environment creates these kinds of structured stress create cumulative stress in workers. We've had reports in the hospital of deaths in ICUs being linked to the poor communication between staff. That kind of stuff. So where is the work to work it out? I mean, people are trying to do the best job. They're in there dealing with life and death situations. A lot of things are being thrown at them, but at the same time, they don't feel that they have a handle on what they're doing. And then there's blaming.
So this setup, going back to Gerald Kaplan, it's
Right.
not obviously a well-running machine.
Right.
So the doctor is symptomatic of some of the stress. Speculate in the last 3 minutes, perhaps,
Sure.
about what are some of the factors that might be impinging on this doctor to the point where he's so irritable. Assuming, in general, he's a reasonably nice person who isn't always...
He isn't, assuming he's a reasonably nice person. I think the things that's impacting on him is the sense that he isn't being effective, that his capacity to be effective is being challenged on many levels, that he feels blamed, that he is, for some reason, in an extremely defensive position by the time he gets onto the unit. what all has gone into it. Has he been working with some very difficult patients? Had a patient committed suicide or attempted suicide on his watch and he missed something, or was a mismanagement of medication, where we don't know, is there a series of near misses, and he hasn't had a place to work them through and clarify them and get a handle on them. There are a variety of things. And when we find people under stress and reacting with irritability and blaming the family or blaming the patient, this is a type of, if you will, stress-induced kind of transference or a reaction to the other. It's a non-therapeutic stance, and there's a break in empathy. And the more that occurs, the more the person feels that they aren't doing what they thought they could do to help people.
So in your trade, you call it vicarious traumatization. You're suggesting that something is wearing these providers down,
right?
And quickly some of those factors. You've listed a few.
Well, first we've listed the whole issue of the institutional organizational kinds of pressures. The others are the populations that come under the care of people. And here's where the issue of vicarious, you mentioned the word vicarious traumatization. What do we mean here? When you're dealing, particularly let's say in psychiatric settings, DSS, prisons, what have you, with populations who themselves have huge trauma histories, complex histories of betrayal, abuse, exploitation, pain, degradation, this whole issue of trauma. When these people come and you're trying to relate to them, first of all, they don't trust you. So they're going to react to you in many ways as if you're the perpetrator of their pain of past years. And that has an impact on you, the interpersonal impact. Then if they begin to tell you their stories, which are just horrendous often, just horrendous stories, you, in trying to have some connection and some empathy, begin to take on in your own mind and imagination those stories. And I can give you some examples.
Okay, so after the break, let's do that, because I'd really like to look at that more closely, and maybe you could help explain to our audience sort of how it works, how it takes on, and how it eventually might make me cranky. So after the break, perhaps we'll start with this.
Okay.
Thank you.
Yeah.
I forgot to file my taxes.
No problem. I'm a tax preparer, too.
I can prepare your taxes, and we'll use IRS e-file to file from here. It's the fastest way to file.
Moonlander, this is Mission Control. What's going on up there?
How do I know they've got it? You'll get proof your return has been accepted. You know, Bob, IRS e-file is so accurate, there's less chance of getting one of those letters from the IRS. I hate those letters.
I didn't know he did taxes.
Nice refund. And with IRS e-file, you'll have your refund in half the time it usually takes.
E-file?
My refund's already in my account.
Well, that was a fast round trip.
Ask your tax preparer to use IRS e-file for a refund in half the time. Click, zip. Fast round trip.
You may feel alone as you face life's most difficult moments. At times like these, you might feel vulnerable and confused. If someone wants to invest your money for you, call us. We can check them out for you before you make any decisions.
Our securities division now registers all brokers and financial advisors. Don't be pressured into making a bad investment. Know all the facts. Before you invest your money, call the securities division at 1-800-269-5428.
So let's continue.
Okay.
How does it work? If you could present sort of how it wears on a provider,
Okay.
and what gets to the provider.
What gets to the provider? Again, I think examples help,
Okay.
because these are real things that have happened to people and that I've witnessed. When I started the doctoral program in psychiatric nursing at BU, my colleague was working with a woman who had had numerous hospitalizations for psychosis, and had been in all forms of treatment during that period of time. The important point here was that my colleague had had tuberculosis as a young woman and had what they call a plumbotomy, so she was distorted. Her body was twisted. And that became a central part in this patient she was working with, this woman who was a little bit older than she was, who was very cranky and very crabby and tough to work with in many ways. But what happened was that the patient had pressed the issue about what happened to my colleague, and she did share what happened. With that, for the first time, this patient talked about her survival as a Holocaust victim. She had never brought it up in any of her therapies. Now that's kind of an interesting dynamic of what it took for the woman to begin to talk about it, what kind of equalization thing in the relationship. But as she talked about the horrors of what she went through, that were really contributing a lot to the psychotic reaction she was. The vividness of it, which she was even protective of how much she would tell my colleague. And with good reason, because as my colleague heard these stories, and her empathy, and her, the images that came to her mind, the sensation, the conflicts, she would carry them home with her at night. She would have dreams about it. Now, this is the inner dynamic where we can see that the traumatic life events, at least that part of them that are revealed to workers and what they have to witness, can impact on the provider. The other part that I had been talking about was people who have been traumatized don't trust people. And so they can be very tough in the way they relate to you. Very complex and very mystifying. And that can provoke stress in the provider if they don't understand what it's all coming from.
Well, that one, I think
Yes.
that dynamic, I think we can all quickly identify with. The many clients who, to test the relationship, have to really devalue you, test
Right.
you,
Right.
and basically prove to you how incompetent you are.
So that raises you don't work with people without having some kind of change in yourself. You know that if you connect with people, you change too.
Okay.
And that can begin to challenge and raise levels of
Okay, but I wanted to
tension.
ask you about the challenge.
Okay.
Why did your colleague start to dream? Why was she taking home so much of this? This patient obviously needs to share, and a good part of what human service providers do is to allow
Right.
hopefully some sharing. Why was it to that extent impacting upon her where it was affecting her own sleep?
We never know which one gets to us, so to speak.
Okay.
You know, part of the idea of people sitting in a room and listening to people and being open to them is to make some kind of human connection, which has, we hope, some kind of positive curative effect, and reduces the sense of being alienated and in a distrustful world. That requires an empathic connection and kindness, and that's stress. It's stressed by the nature of the information and how it impinges on the person hearing it. Sometimes it is just so vivid. Now, sometimes you aren't even aware of what part of the information you take. Then you have to look at where is the person in the provider network. Are they a beginning trainee? Are they the least prepared and supervised person working at the front line with the most difficult cases? The idea of being involved and 100% involved and detached simultaneously takes a great deal of wisdom and maturity to develop. Okay.
But, you know, I'll give you an example.
Sure.
I've never met this fellow before. It's my turn to do an evaluation. And he comes around the corner, and he looks at me, and he goes, "You're an effing..."
Right.
Now, already they were going to the officers, this was at Bridgewater State Hospital, were ready to just take this guy into seclusion and protect me and get rid. And I say, wait a minute. So I say to this fellow, wait a minute, I'm curious about something. Can I talk to you? He says, yes, you can talk to me. And so I interview him, and I said, well, I'm very curious. We've never met before, and you came to an opinion about me. And I want to know how you came to that opinion. I'm not going to tell you whether you're right or you're wrong. You may be right, you may be wrong. My point, and I guess my question is, I don't feel that I'm an effing, you know. So when this stranger accuses me of that, I can say to him, that's kind of interesting. How did you come to the conclusion that I'm that when you've never met me before? That was the beginning, by the way, of a very good relationship that he and I struck up, because he then began to tell me, as you might expect, that he's had all kinds of problems with men in the course of his life, especially men in authority, and obviously whoever that psychiatrist was, when he rounded the corner, was going to be another male figure who was going to abuse him.
Right. George, it reminds me of a woman that I brought in for with a colleague of mine for a drug consultation, and the psychiatrist was sitting across from her. The first thing out of her mouth was, I know you don't like me and don't want to see me. And we both blinked, you know. and he basically said the same thing to her. And she said, well, if you think the way I do, you'd know how it came about.
But
that's
he wasn't affected.
He wasn't affected.
Right.
You're talking about skill, years of experience. First of all, you had lots of people calling you all kinds of things for a long time.
They weren't all patients either.
And they weren't all patients. They were staff and everything else. And you learned how to sort that out. Those are called coping skills and coping mechanisms. All right, let's go back to the example I gave of my colleague. She didn't talk about her deformity. Interestingly enough, both women were very attractive and both deformed. Put her at risk, maybe. You know, I speculate that it was a vulnerability thing. Now, what I have to say about my colleague is that through supervision and work with it, and, you know, she began to work with it and certainly took care of herself. You know, she managed this and maintained an empathic connection with the patient. But it was a critical period for my colleague. It's kind of interesting. I just taught a class on this stuff at the graduate school at Boston College, and two of the students. One is a young man who has worked with VA veterans, and then he said, "Gee, I just remember having these dreams that I was in combat, and I woke up and I couldn't tell whether or not I was in combat." And another young woman who was working with a lot of rape victims coming into a situation, who began to dream about rape and get nervous when she was out in the car, but it was carried over. So what we have to look at is, in the whole training and preparation of our healthcare providers, we take the issue of the recent thing, going in and finding the deprivation and the filth in the DSS and young workers with very little support, because as a nurse I did take students to work at DSS, and boy, it really gave me a different view on the healthcare provider system, because we're expecting so much of people with such horrendous life situations that they're dealing with very little in the way of support and backup for that kind of work. And so these are young people developing. They're taking on life tasks. Should I get married or not get married? Who am I? What kind of work am I going to do? I mean, we have to understand people are growing up. Whether they're young, I call them baby docs or nurses or social workers or young policemen, that they're, and maybe this is part of my retirement of having kind of a sense that support has to be out there for the development of people into well-functioning, coping human beings. And we need, they need to know how to take care of themselves, as well as the system in which they're working needs to know something about what they do to provide support for their workers.
Okay. So we're going to have to take a break.
Okay.
You're suggesting that people in the field bring their own vulnerabilities, basically.
Absolutely.
Some of it may be related to where they are in the life cycle. Some of it may be related to personal trauma, personal experiences, but they bring vulnerabilities.
Sure.
So maybe when we come back after the break, we can talk about sort of special populations that might play on those vulnerabilities.
Yes. Okay.
and be more likely to be settings where people providing services are going to be traumatized.
Right.
So after the break, maybe we'll pick up with that.
Yes.
Excellent. Thank you.
Welcome to a land of law, a place ruled by the dinosaur, where cactus-clad mountains spew lava and smoke, and craters hide inquisitive folk, where wise old turtles share their views on creatures with red vests and powder blue shoes. There's so much to Galapagos, so much we could say. 'Twould be most preposterous if it all went away.
What do you want to leave your children, the story or the place that inspired it? Since 1961, World Wildlife Fund has helped safeguard thousands of species like these, animals which can be found nowhere else on Earth. But in areas like the Galapagos Islands, we need your help to do more. Phone us at 1-800-CALL-WWF to find out about World Wildlife Fund's Living Planet campaign and about our free action kit, which includes information on what you can pledge to do to help leave our children a living planet.
If you're hanging out with people involved with drugs, do this now. Make a list of all the things you like about your life, things you don't want to lose. Carry it with you. Tack it up on your wall. Think about it before you get involved with drugs. Make that list now, or you'll have a long, long time to think about what you've lost. Federal laws for any drug involvement are tough, with no parole, ever.
Sans soleil, la fleur périt, et puis s'évanouit. Oh, quel malheur! Les oiseaux chantent.
Would you react the same way if you found a suspicious spot on yourself? Melanoma is dangerous. Examine your skin regularly. This message is from the American Academy of Dermatology.
So, Carol.
Yes.
We've kind of set the stage to talk about special populations because we know that many of us bring certain vulnerabilities to this work.
Right.
And maybe there are certain populations that are likely to end up creating more stress on providers. So perhaps you could talk about some of those special populations.
I think within the area of special populations, we can also look at the providers in those areas and the kind of settings. If we look into the new millennium and where people are going to be housed, so to speak, in terms of services, we find we have the area of the prisons. We have the whole area of the elderly. We have the problems of the mentally ill and how they're managed and treated in the community. And then we have the whole area of the sort of the dual diagnostic people with emotional problems and severe health problems in the community. If we go into the area of children and mothers and what's happening in terms of DSS, for example, we have the impact of poverty, the impact
welcome to Mind Over Matter, and today
abuse,
it's a pleasure to welcome Dr. James
abuse
Gilligan.
Just doesn't affect the poor, but the incidents can be more because resources are less for people. The workers going into that area are particularly vulnerable for a couple of reasons. One, if we look at the pay scale and the training levels, let's say of DSS workers, mental health aides, technicians, they're at the lower end of the continuum. And yet, they are the ones having the most daily contact on spot with the more traumatized, ill,
if the violence is being caused, the effective way
alienated
to prevent that
groups of people
is to treat the mental illness.
in the prisons.
If the violence is being caused by the mental illness.
You know, when the Mental Health Act began, we knew that we were hospitalizing people in prisons, and we're back to doing that.
Okay.
You know, we have.
But so what?
And so then you have your guards working within this area, and healthcare providers trying to work. Now dealing with another kind of structured stress between corrections versus therapeutic effort.
Okay. So you're saying there's a mixed match, really,
Yes.
that the providers aren't necessarily trained to
Yes.
take care of the special populations because now some of those special populations are appearing in places that are different now than, say, 30, 35 years ago,
Yes.
prisons, nursing homes, et cetera,
Right.
et cetera. So how do these special populations, though, wear the providers down, and why do they wear the providers down?
Probably the most obvious way that they wear providers down, and it goes way back, is the threat of violence.
Okay.
That's number one. The other thing that wears the provider down is they can't get a handle on what to do to help people stop behaviors that are so self-destructive or destructive of other people. And yet they feel some kind of responsibility.
So they're made to feel incompetent?
Incompetent. I think, we had been talking a little bit earlier about the recent number of articles in the papers regarding the House of Horrors and the criticism of DSS and what have you. And as a matter of fact, I used that information for an exam question for the students because somebody had recommended, well, psychiatric nurses should be in there, taking care of them. And it was really a baited question for the students because then, they thought they had to take a side. And my point to them was basically, be careful when professionals are pitted against one another. We're missing the point here. Now, what you get here is a demeaning of the professionals. One pointing a finger at another at this, the devaluation of social workers. And recently there's a new situational comedy on, I just saw it last night, with this god-awful presentation of social workers. It's really, making a mockery out of very, dedicated people doing very hard work under sometimes, just unbelievably non-supportive situations. And when this occurs because of the politics of financing power, whatever it is, its impact on the public and on the worker. How do they feel good about themselves? How do they feel good about the work they're doing?
To the climate.
So the climate, devaluates them. Okay. So you have populations who are then stigmatized. Working with a criminal, working with somebody who's mentally ill. We're far from people accepting people who have emotional problems. It's just, the stigmatization is always there. And then you are somebody who works with them. So there's further alienation. So all of these things begin to alienate the worker in these settings and create stress on the worker and result in behaviors that are less than helpful to other people.
Okay. So we had talked also during the break about many workers are sort of feeling more isolated, and I think in the last segment we're going to try to maybe talk a little bit about the antidote, what one can do about this, but the climate today is one where you tend to be working more solo. You're not part of a group.
That's one of the most fascinating aspects, I feel, of the so-called privatization and managed care. If anything, the care has gotten more fragmented, and people are working solo, and then if something happens, it's their fault. So if we keep getting back to the systems problems that keep creating stress. But, I've been on wards, hospital wards, watching doctors who have had tough nights. And they meet in the morning, they're doing their charts, and then they kind of pass one another like ships in the night. There isn't any kind of connection. There's the isolation. Then when you get into some of the clinic management, students have said this. Gee, you get a patient, you go in a room and everybody disappears. There's nobody there. So in the outpatient departments, there's this isolation. And we've had, violent outbursts and stuff in those kinds of settings that have been threatening to workers.
Why are nursing homes, do you think, stressful environments for providers?
Well, first of all, nursing homes are being utilized much more for the management of mentally ill patients. And again, we have a gap in the preparation of people in the nursing home managing them. And for that matter, there's a whole host of issues within the nursing home. A lack of understanding of what's going on. People have a stroke. And I've gone into nursing homes and the person had a stroke. Their food was set down on a table and they're laying flat in bed and nobody's feeding it. There isn't the connection of what to do in terms of feeding the person. Nobody takes time to figure out how to communicate with them.
But how much skill or training does it require to know that you should place the food?
Obviously, it takes quite a bit, doesn't it?
Well, it takes a lot of common sense, though. Is that being left out?
Oh, what the world would be like if we had common sense. We have these, undercover cameras going in and seeing the kinds of care that go on in nursing homes.
But the providers are not, as you said earlier, malevolent. I mean, they're not intentionally. So what's not happening, say, in a nursing home? We only have a couple minutes left before the break.
Well, again, I think there has to be leadership, and it has to be clinically driven leadership, and valuing the members and their input to the clinical management. And that clinical leadership involves the patient's families or significant others. Rather than a nursing home being a place where everybody's just waiting for people to die, it has to be a vibrant place where people are living. And it takes that kind of energy to go in there. But if we have all of these other kind of maybe well-intended but nevertheless corrupting forces, that the bottom line is whether you charted this or you did that, cover yourself on this by making this happen. Okay. When you begin to find people spend more time away from the clients that they're working with or the patients, something's going wrong in that system.
So you're basically suggesting that it's a disrupted system,
right?
That pulls providers away from the bedside and has them do a lot of things that they don't feel are particularly important, that don't really have a lot to do with taking care of the patients, but have a lot to do with keeping themselves out of trouble.
Or they run into a wall of not feeling what can they do to really take care of the person. People are written off. You have to have unbounding curiosity. That's what keeps you going. You're always curious. The guy comes in, he calls you something, and the first thing that comes to your mind is, why did he say this? Now, if we could develop that kind of fun, and that's fun.
Yeah.
That's enjoying your work. It's enjoying the person. It's enjoying the challenge of, where did this come from?
Mm-hmm. Okay.
But people on the bottom of the pile don't often, they have problems at home. I had to have home health aides come in during a period of time when my mother was ill. And some of those women, they were leaving their dying mother at home to have a job. There was little input for those.
To take care of your mother.
Yeah.
Okay, well, after the break, maybe talking about the person who's actually providing the service, maybe we can talk about the kind of systems that need to be in place so that people feel, valued and in a setting where their competencies are being enhanced.
Right.
So we'll pick up with that in the final segment.
Okay.
Thank you.
Wherever you go, you see the signs. A new century is coming, and with it, 1,000 questions. Will there be peace? Will your family ever be in harm's way? Will a small town in Texas be hit with a hurricane? Will your daughter ever need a new kind of blood treatment? Will that nice man who hands you the paper ever need a hand to hold in a time of need? We have no crystal ball for the world that awaits. Just one promise. We'll be there. Whether it's in the eye of the storm, in your darkest hour, in your time of need, or in the light of day, we'll be there.
In
every corner of the world, there are rare and wonderful animals in danger of extinction. When you visit the San Diego Zoo and the Wild Animal Park, you can see them. And when you join the Zoological Society of San Diego, you can help save them. Because without your help, the world's most precious animals could simply fade away.
So we seem to have come down to the crankiness has something to do with more than a bad day. It has something to do with feeling that you're not very competent, perhaps, and that your work is not being valued, perhaps. So, and maybe it goes back to Gerald Kaplan. How do you develop a system that supports, nurtures, cares, so that providers can develop the kind of curiosity that makes them want to go back to the bedside and work with a particularly challenging patient and population of patients?
George, this is purely speculative. This is my utopia. How would you develop the system? This is, I guess, what my whole professional career has been about all these years. The first thing I like to just talk about in terms of the providers themselves and the kind of accountability and responsibility they have to take for their own health and recognition of this kind of cumulative or traumatic stress in their work setting is to pay attention to some of the behaviors. And Perlman and other people have done studies on this. One of the more peculiar kinds of reactions you can get from people who are overwhelmed, health providers, is that they begin to take on more. They overcommit themselves.
Okay.
And with the overcommitment, it's a kind of a strange behavior. They take on more. They have this whole backlog of stuff that they can't get done, but they take on something new. It has initially, it gives them a sense of being lifted. Here's something new, here's something I can do. And then, boom, they get stuck again. The others are really changes. We've talked about the change in sleep patterns, becoming more irritable, using alcohol, substances to try to relax, to take care of themselves, an inability to really enjoy simple pleasures in life that they are used to, increased conflict with their families, becoming more isolated, becoming more critical of themselves, more critical of coworkers. These are kinds of clues that a provider can begin to say, gee, if I'm beginning to feel all of this stuff, what do I do about it? Well, one, it would be a good thing just to go talk to somebody about it to begin with. And then the other is to begin to do things to take care of yourself.
Like what?
Exercising, good diet, drinking, making sure you have enough, that you're hydrated. Nobody thinks about working, and they drink all this caffeine and coffee, and they become dehydrated. They have a headache by the end of the day. They're not drinking water. There isn't a break. So there are all these self-care kinds of things that have to be thought of at the individual. Now, the bigger problem of how do you maintain systems that are basically healthy, so that
Okay.
that takes the commitment of the consumers of that system, the system managers themselves, and the workers in it. And that means that people have to begin to evaluate and come together and work together. Now, unfortunately, some of our efforts in trying to, through the years of how do we work with workers and managers and labor unions, how do you organize to get things in, have ended up being more adversarial, rather than cooperative.
So we're talking about utopia, though. So build some of the systems. How do you do it so that people...
First of all, I think one of the things, when I was a young nursing student, I thought the mission of a hospital was to take care of people.
Okay.
And actually, the mission turned out to be something much more foreign to me. It had much more to do with a hierarchy of power and status and stuff within the hospital. Okay. That led to, some early disillusionments about what are institutions. But it does say, well, look, how do we begin as an institution to say, what is our mission? How do we bring in everybody to achieve that mission? Therein begins to build some kind of unit. Yes, you need to sustain the institution if it's going to keep producing. But you have to somehow marry, if you will, the methods of sustaining the institution with the mission of the institution. If the mission is to provide the best quality health care service in the most efficient manner, but then to sustain it is just to keep cutting costs, then we're in some kind of major trouble. And then there's the matter of, how we're going to do, how we're going to do it.
So let's be concrete in our closing segment.
Right.
We know we're in trouble. We know the cost containers are sort of winning, and that providing care is harder and supporting staff is more difficult because, quite frankly, it's not considered cost-effective to have staff meetings and.
The point is it's more serious than the existing staff. The environments that we have for training professionals is no longer going to be there, and I don't know what we're going to come out with in the way.
Well, what do you mean? I'm not sure I follow.
Well, the educational the support for the education of novices in the system.
Before they hit the field, or in service while they're in the field?
No, you're training young doctors, young nurses, lab technicians, whatever. How do you, in a cost containment environment, continue that kind of educational system? Now, one of the ways it was handled, or potentially the way that it was aimed at it being handled, was certainly to have the kind of development programs to maintain good care in the hospitals being exemplars for those young professionals, that they could participate in them at some level, and they could also be the recipient of that kind of knowledge of how to work together, how to evaluate your work. I think one of the more heartening, I don't want to be heartening issues, was the efforts after some of the disasters on the cancer treatment drugs, that people really were working at, let's not blame. If there's to me, a professional is not somebody who doesn't make a mistake. A professional is somebody who can pick up their mistake and face it and lay it out there right away. That is monitoring, that constant monitoring of their work. You have to have that kind of trusting environment in which to do that. And for those people who are looking at the money as the bottom line, they're going to lose in the long run. They're going to lose in the long run because you're really putting money into systems that are not being effective, so it's a waste of money in that way.
So there is a bottom line, though. The systems, and I guess it's again back to Gerald Kaplan, I mean, the systems...
And the systems don't exclude the consumers, in my mind. Consumers have to be, they're a central, absolutely vital part.
Okay. Although it's hard to get everybody into the same room, onto the same page, agreeing. And I guess the task around burnout, vicarious traumatization, is to somehow have people do complicated and difficult work, but to feel along the way that they're getting better at it, that their competencies are increasing, not diminishing, even if a
Right.
patient dies,
Right.
or even if one particular patient doesn't respond to the
Right.
best of your
Ability.
intentions. So that the systems have to help people feel valued while they are gaining more competencies, and you're suggesting that that's becoming sort of a thing of the past.
It's becoming a thing of the past, and the leaders who have that, you have that kind of energy, that kind of curiosity. There need to be models for people too, of whether it's a nurse, doctor, social worker, people with that kind of that wisdom and enthusiasm. And it is a matter of wisdom and enthusiasm to help younger people have something to aim for. They're idealistic, but then they get torn, in different directions.
Well, I think one of the things we do in the New England Medical Center South Boston program, it's a little new for me.
It is
well,
new.
30 years new, but is to give the students, I think, a kind of a system so that not only do we help them laugh a little bit about the work they're doing, because, sometimes the tragedy is a comic tragedy, and I'm not suggesting that we ever make fun. We never do, and that's totally unacceptable, but sometimes we can laugh about aspects of the work.
And aspects of ourselves.
And aspects of ourselves. Right. I think we
laugh with patients.
Yeah, or we laugh with them.
Yeah, we laugh with them. That's what I said.
Exactly.
Yeah, absolutely.
And then we give them an opportunity to sort of talk a little bit about how stressful it can be. And I think the word you used about me, which I do appreciate, is help them really develop a healthy curiosity about why either people don't use their appointments very well, or why they don't seem to remember to take their medication, or why they don't whatever.
Can I
yes.
tell you?
Because we're going to have to wrap up.
We wrap it up. This is a little consultation thing I did at a hospital. It was an inpatient unit, and the nurses were feeling discouraged because they didn't feel as valued as the therapists on the unit. So I negotiated with the patients, the nursing staff, the therapists, the psychiatrists, that for a whole week we were going to reverse roles.
Reverse roles, yeah.
on the unit, and the patients would be the ultimate evaluator of all of this. At the end of the week, it was really a marvelous experience. The patients,
1 minute left.
They had a wonderful time. The patient said, "Oh, this is a friendly nurse." The nurses wanted to go back to being nurses. The therapist said, "It's too hard being a nurse. I want to be a therapist." I mean, you can do things like this in systems that begin to help people gel and come around and value one another.
What I really appreciate about you, Carol, and I think it's really one of your gifts to the field, is that you really have helped us all think a lot about it, that these are problems that you do have to think about.
Right.
And once you think about them, they're kind of challenges. It's kind of creative to think through how you keep people going in the field so that, in fact, they don't burn out, get discouraged, and just decide, that maybe there are greener pastures elsewhere. So. On behalf of the Alliance and Mind Over Matter, I want to thank you for being here with us today, and really appreciate you being here. Thank you.
Thank you.
We should keep talking.
Yeah.